would just really like to welcome everyone to this, our very first ever Rapid Improvement Workshop. And I know that the team has worked long and hard from week -3 to now the event week. And so we really do look forward to the results of the Rapid Improvement Workshop, as well as some learnings down the road about the process itself. So I will turn it over to the team, and we really are very excited about this day.
You guys look like a great group here. Good afternoon, my name is Pat Stewart, and I'm the team lead for this RPIW. This is our agenda, and we'll be operating to a tack time of 20 minutes. This is our team picture, and the team did a great job. Here is our project form, and our focus was on from when the referral came in and was then the appointment was scheduled, and what we looked at were the mental health outpatient counseling clients. When we look at all our referrals, what we know is that 38% of total referrals for counseling are actually scheduled. And this is our target progress report and results sheet. As you can see, at the beginning we made had some baseline measures and then some targets. So I'll just point out one of them. For example, the walking distance was 164 feet for the letter and the appointment letter required, and our goal was to get it down to 82 feet.
So now I'll talk about the value stream. I'm Cynthia Lichtischen, the sub-team lead for this project. And so if we take a look at this very high-level value stream map, we see that the wait time for clients really is significant in the time when the intake is completed to assigned and then to being scheduled. So without the appointment even being scheduled, we're looking at 2 days, 15 hours, plus 2 days, 7 hours to 3 days, 7 hours. And that's before anybody's even contacted for the appointment. What this high-level value stream map tells us is that the lead time from client referral received to appointment scheduled can be anywhere from 6 days to 26 days. So the value added from the client's perspective is 0.45%. The non-value added is 99.55%. This is a more detailed value stream map that we did, and it just really shows the total time, and it looks at the phone and the letters. So it just is a little bit more detail from the first one. The data collection sheet we weren't able to get all the information that we needed from the metrics, and so the counselors helped us put together this data collection sheet. And in the data collection, we were able to look at when the referral was assigned to when the appointment was scheduled. We used this data for a lot of the value stream mapping that we did, plus the other assessments. So some more information that we used in order to do our value stream map and all of our assessments is around the average wait time. So with the batching of referrals to the Friday meeting, it can take on average, and we looked at the referrals coming in daily, so we took an average of 2.65 days from the intake being completed to the case assigned to a counselor. And the tap time with all the data that we collected showed 48 minutes and 45 seconds.
So now we're going to look at the process we changed. And so pre-Kaizen, this is a time observation form which shows our counseling intake process, and the length of that was 37 minutes and 17 seconds. And this is a standard work combination sheet which just shows that same counseling time or same intake time. The long horizontal lines that you see, those are where the client is assessed and the assessment is entered. This is a percent load chart, and what this shows us is how many people we actually need to do that process. And if you can see in the top right-hand corner, we need 0.72 people to work on this process. Here's our idea summary sheet, and that's just showing how we're moving the scheduling process into the intake process. Here's a time observation form post-Kaizen. So what we did is when we moved the scheduling process into the intake process, we timed how long the process took. And the process took 38 minutes and 50 seconds, and so that's 4 minutes longer than the process took prior to moving the scheduling portion to intake. And this is just more detailed observations, time observations. And here's our standard work combination sheet, which shows the inclusion of the scheduling into the intake process. And if you look, no, so that's just, sorry Cynthia, no, you can turn it. Thanks. Here's our percent load chart with the new process, and you can see on the chart that we've added the client scheduling to the intake process. And what that has done is changed the number of people we need from 0.72 to 0.8 of an FTE. So it hasn't moved a lot, and what it's important for you to know is we actually have 3 part-time people doing this work. And when we show you the 0.8, that's if that's all these folks did. They didn't have any interruptions, they didn't attend meetings, that is just that amount of time. And here's our time comparison. I'd just like you to look at the phone portion. The lead time pre-Kaizen was 6 days, between 6 days and 15.5 days. And it's amazing that post-Kaizen, we are now down to 40 minutes. So that's how much time we have taken off that process. The value added, as you can see, was less than 1%. And now we have moved the value added to 98%. And this is just showing the new value stream. And we did some standard work for the new process, and we also did training.
Hi, I'm Margaret Ralston. I was on the scheduling team, and this shows that there was some problems. We didn't really know how to use Health Suite for scheduling. So what we did was we went to Addiction Services, and we got some ideas there. And one of the things that they were using there was a procedure on the Health Suite called New Client. So we decided to incorporate that. And what we did was we asked one of our admin, Chris, to add New Client to our Health Suite template so that we could use that. And that's what this looks like when it's on Health Suite. And being a psychologist, I realized that this New Client procedure didn't really work very well for psychological assessments. So I decided that, and with some input from some other psychologists, that we needed one that would be longer, and we called that one New Psychological Assessment, and it is the same color, but a longer space. And Chris added that to the psychologist templates for Health Suite. And we timed how long it takes, like from the beginning, how long it takes a clinician to put one of these New Client procedures into our Health Suite. And management sent out an email to instruct all the clinicians to add these New Client procedures to their Health Suite. And that was the email. Then we did some training with the intake staff because they didn't know how to use Health Suite for scheduling. So we did that. And we developed some standard work around the steps that they would have to take to schedule clients for us at intake. And that's that part.
Hi, my name is Carol Massescapo, and I was on the defect deletion team. What we found was that we were receiving referrals from all different sources with all different information and different formats, which was making our work a little bit more difficult with not having all the standard addresses and names and ages and what the referral was for. So we found that there was a referral already being made with all the information we would need. And so what we did, we got a hold of that and we started improving it, finding out what information needed, how much room we needed on there. So we come up with one standard form for addictions, mental health, and psychiatry for everybody, all across the board. And so each one has standard information. Then we found that we were getting them all by like faxes and emails, and to get out the information, we come up with a letter, because now everybody has these different forms. Now we have one referral, and we need to get it to everybody now. So we come up with this letter that we're going to send with this new referral, which says what information is very important, the phone number, name, and a note on that will say if the information that is not, if the information is not correct or not filled out, especially the name, number, address, we will just send it back to the referral source.
Hello, I'm Tina Pohl, the happy volunteer, and my role has been that of a client. And I joined the defect and deletion team. We came across this big black book in the office that is used by all 4 clerks to record their referrals. Now, Matrix would do exactly the same job, but there aren't enough headings at the top to have a proper recording of the entries. The staff is receptive to have Matrix in the future, and the black book would be eliminated, and we have documented that for further follow-up. Now, my role as a client was, first of all, I was overwhelmed by the huge job that the team had to do, and I congratulate the health board and thank the staff for including me as the client. I never felt left out, and with the changes in place, I see how the clients can benefit by faster contact, to seek help, to be listened to be understood, and to know we are not forgotten. In our dark world, it is important to know somebody cares today rather than tomorrow. With the rapid improvement in place, faster bookings and processing will surely help us, and in the end, help the staff as well.
Hello, I'm Doug Dahl. I worked on the defect deletion team. We've got a couple of issues that we worked around. We were looking at an electronic handling of the referral forms. We developed a process, sort of mapping out all of the different steps, taking the current paper movement and putting it electronic. One of our challenges this week is we found out there's some implication problems with that. One is getting a fax number set up. We were going to have a common fax number and then have it fax and go to email. We've also got some issues around the security of email and electronic communication that need to be worked out before all of this can be implemented. So we've written a lot of standard work pieces to go along with this, but we're going to be leaving that for others as it goes forward in the process, and once some of those other issues around both the fax number and the security issues are established. We hope that this will help reduce redundancy and saving files in the future. One of the, I'm going to talk a little bit here about the parks travel. One of the things that has happened is with the assignment on the Friday meeting, there was the referral form had to go to the Friday meeting, you walk it back to the office. That's not going to happen anymore. Instead of traveling 121.5 feet, the appointment's being made by intake, so there is zero walking for that process. The other one that happens is when clinicians get their assignment, they go back to their office, they make phone calls. If they need to prepare a letter because they're not able to reach the client and have it sent out, this is a big long spaghetti diagram showing you all of the steps that are taken. 164 feet of walking between the clinician and the admin staff to get a letter out. Because the appointment is being made at intake, we now have zero walking required for that and zero time involved in doing that process because it no longer exists, moving that work to intake.
Hi, my name is Kyla Oakes. I'm one of the intake workers at Mental Health, and we had Anton come downstairs and 5S my office, and so my pre-score before he came down was 2.5. And this is my desk before. Yes, it's embarrassing. That was here's my drawer before. That's really bad. Keep going. Then we went in and we 5S'd it, and I came up with a 3.4. And here's my desk after. And here's my drawer after. And here's my new shoe rack. And so the benefits of this was that it made some room for me to sit at my desk in front of my computer and actually be able to write on a document in front of my screen. So we just did some shuffling. And I thought it was helpful because it was so neat and tidy. It just kind of felt better being in there. So overall, I really like the process. It was really fun.
So this is the newspaper, and it listed all the work that was, the ideas and things that we were to be tasked with to do this past week. And everybody worked extremely hard, and a lot of the items on this newspaper are 100% complete, some partially completed, and then there are some that still need to be worked on past this week. So this is our target progress report, the final one. And what I'd like to bring your attention to is the percent change. So I'm just going to review a couple of areas. So for example, our walking distance for clinician appointment letter required has gone, saved 100% or gone down 100%. And also if you look in the middle of the chart, our quality, some of our defects were around that we had no standard work for processes. We developed standard work, and so that defect is 0 and has been improved by 100%. So our workshop summary. We accomplished a lot and we learned a lot through the process. We created an electronic referral process. We developed a process to schedule clients during intake. And what we learned is how important standard work is, and also how to deal with resistance to change. We also found out that timing processes are much harder than they actually look. And the most important thing is that our clients now have quicker access to an appointment, and this is really important for client safety and client satisfaction. So to make this a success, this RPIW a success, it involved many people helping the team, and here are just a few thank yous. For our client representative, Tina, all our mental health staff, with special thanks to the following. Also IT, Steve Gerard, addiction services staff were very supportive, and last but not least, Dr. Java's staff, who kept us nourished throughout the week. So now I'm going to turn it over to Brett Enns.
He's our sponsor, and he is going to talk for 2 minutes.
Oh,
You do have
they
a
already
time.
cut a minute off. I was told I had 3 minutes, so there we are.
Okay, did I tell you 3 minutes?
But it's okay.
Yeah, you have 3 minutes.
Okay. Well, first of all, I just want to say thank you to the team that has worked so hard over this past week, and the work that you've done. Our service is a very challenging service. Every time I go out, people are asking for more service, and our clinicians do a wonderful job. The work that they do, the people they serve, they do such a good job, and any approach that we can use to streamline, so we take that kind of organization or administrative piece out of the process, is so much more beneficial to our clients. And I can't tell you how much I appreciate the work that you've done. Thank you for those of you that showed up today. I don't know if I've ever been to a report out that's had so many folks, and I just really want to say thank you. It's good to have Sensei here today, and we certainly appreciate your piece in this work. And finally, to Deb Dollard. Deb is our consultant with JVA. It's been a pleasure to work with her, and she marked me on my lean leadership, and she said she's just getting ready for me to be a part of this process. So I'm not sure I'm ready, seeing all the work that you've done, but thank you so much for all the work you've done.
You're welcome.
All right, well, I really want to congratulate the team for our first RPIW. You did a fantastic job, lots of hard work. One of the things that they did is they went to the addictions area, and they saw how they were doing the scheduling, because they are the intake people do the scheduling. And so I just really like the resourcefulness and leveraging what was going on with other organizations, and also looking at the integration of that within Victoria Hospital. I'm especially proud of the KPO for taking on leadership roles in the first RPIW, because they're going to be supporting the future RPIWs, and now they really know what it's all about. And so they'll be sympathetic, and they'll also really, I think, give good support. So RPIW 2 is in prep week right now, following fast on our heels with Sensei Narita and his translator Etsuko. So I know that the team leader and sub-team leader are here saying, okay, what are we up for in 3 weeks? So I know they've been working hard. So this team really overcame a lot of challenges in trying to measure data in week -3, because so much of it, somebody said earlier, gee, you don't need a stopwatch for this process. You need a clock, because you need a calendar to measure it, because there's a lot of delays, and so in terms of trying to find out when it was that after a counselor was given an assignment, was given in a case, till the time that patient actually got scheduled was difficult. But the team found ways to overcome that, and we were able to move on with the data. And so this team has been able to reorganize the work. They've taken a lot of waste out, as you've seen, in terms of how much waiting was going on. So we've got a client at home who's under mental stress, and they're waiting and waiting because there are all these waits in the system. And so with the good work, we were able to take that out, and now patients are going to be able to have their appointment on their schedule just a lot earlier than they were before. And then there were the team, the defect deletion team. They were also working, because we know we added some extra work to the intake workers to their day. Well, the defection team was really trying to find ways that we could take the waste out and make things more efficient for them, and to free up, even just a couple of minutes that would give them more time to be doing the scheduling. Another thing that happened was the team had some great ideas that they went out and they tried, and we call it fail fast forward, because some of these things, like when we looked at the black book, the organization just isn't ready to get rid of that black book. But we still talk about it and we celebrate that we went out and we found out about it. The organization is now smarter in terms of, well, here's what we found out and here's what we have to do. The same thing with wanting to use the email more extensively than we were able to this time. But a lot of work has been put in planning, and we know about the areas where we've got problems that we'll have to overcome sometime in the future. But we want to celebrate. We don't want people to say, well, I can't go out and try something if it's not going to be a success. We only find out by trying. So I think this team really pushed the boundaries, and they tried some really hard things. And most of them worked, and some of them didn't. And they're all valuable. At this point, we're going to be turning the work over to our process owner, to Gary, and look for him carrying on, making sure that what we've implemented, cleaning up the last few of those issues, and making sure what we've implemented has a smooth transition. So I think that you're off to a really good start with your RPIWs. Yeah, so I'm ready to do more of these with your team. It's really great. Okay, so she's officially handing the package over to Gary. She's like, I'm done. Here you go, Gary.